All right, let's dive into tracheostomy care. If you're prepping for the NCLEX, you know this is a big one. We're going to break down everything you absolutely have to know, from the basics of suctioning to those high-stakes emergency situations. Let's get you ready.
Okay, let's kick things off with a question that I can pretty much guarantee you will see on the NCLEX in some way, shape, or form. We are going to circle back to this, so don't worry, but just keep it in the back of your mind as we go. When it comes to trachs, being prepared is half the battle.
So, before we get into all the nitty-gritty details, let's just do a super quick review to make sure we're all on the same page. What even is a tracheostomy, and why do our patients have them?
You can think of a trach as a direct, secure, express lane for air to get to the lungs. For anyone who needs help breathing for more than a couple of weeks, it's a much more stable and comfortable solution than having an endotracheal tube down their throat.
Now, let's talk about what is, without a doubt, your #1 priority: making sure that airway stays open and clear. And with a tracheostomy, that all comes down to knowing when, and just as importantly, how to suction properly.
This is so important to remember. Suctioning is not a scheduled task you do every 4 hours. No way. It is 100% based on your nursing assessment. Are you actually seeing gunk in the airway? Is their O2 sat dropping? Do they sound junky? Those are your cues. It's all about your clinical judgment.
The procedure itself is a huge safety point, and you got to know these steps cold. But let's focus on the two most critical actions. First, you always pre-oxygenate the patient before you start. And second, and this is vital, you only apply suction on the way out. You never ever suction while you're inserting the catheter.
And here is a magic number you have to burn into your memory. 15. 15 seconds. That is the absolute maximum amount of time you should suction for in a single pass. Any longer than that, and you're just pulling precious oxygen right out of their lungs. So remember, 15 seconds is the limit.
Okay, let's switch gears and talk about the trach tubes themselves. They're not all the same, and you absolutely have to understand the difference between a cuffed tube and a cuffless one. It's a huge safety issue.
Honestly, the choice boils down to one simple question. Is the patient on a mechanical ventilator? If the answer is yes, they need a cuffed tube. That little balloon creates a seal, which makes sure every bit of air from the ventilator goes into the lungs. No leaks. But if they're breathing on their own, weaning off the vent, a cuffless tube lets air flow more naturally.
Okay, listen up, because what we're about to talk about is one of the biggest misconceptions in tracheostomy care, and it is a classic NCLEX trap question. We've got to talk about aspiration.
This is it. This is the huge takeaway. A lot of people believe the cuff on a trach tube prevents aspiration. It absolutely does not. Just think about the anatomy. Aspiration is when something gets past the vocal cords. The cuff sits below the vocal cords. So by the time secretions or anything else gets down to that cuff, aspiration has already happened. The cuff might slow it down from getting deeper, but it did not prevent it. That's a massive point.
All right, let's talk about the scary stuff, the emergencies. Because honestly, the best way to not be scared is to be prepared. So, what do you do when things go really wrong? And here's the answer to that question from the beginning. This list right here is non-negotiable. This equipment has to be at the bedside ready to go 24/7. And notice, you need 2 spare tubes, one that's the same size and one that's a size smaller. Why? Because if there's swelling, you might not be able to get the original size back in, and that smaller tube could literally save your patient's life.
This is the big one, the one that makes everyone's heart stop. Accidental decannulation. The trach tube just falls out. This is a true medical emergency, and what you do in the first 30 seconds depends entirely on one single critical piece of information.
And that one piece of information is, how old is the stoma? Is it brand new, less than 7 days old, or is it an established stoma, older than 7 days? If it's new, the path to the airway isn't mature yet. So if you try to force a tube back in, you could create a false passage into their neck tissue. That's a disaster. So for a new stoma, you cover the hole and you bag the patient over their mouth and nose. But if the stoma is well established, that tract is stable, and a trained person can attempt to reinsert a new tube. Knowing that 7-day rule is life-saved.
So, let's just pull all this together. We've talked about a lot of really important technical skills, but the real goal of our care here goes way beyond just keeping an airway patent.
You have to remember, when someone gets a tracheostomy, it takes away their ability to speak. Their voice is gone. And a huge part of our job is to help them get that back, to restore that really vital part of their humanity. And that's where things like speaking valves come into play.
It's a really clever little device. It's basically a one-way door. When the patient breathes in, the valve opens and lets air into the trach. But when they exhale, the valve closes. That forces the air to travel up, around the tube, and through their vocal cords. And just like that, they can talk. It's an absolute game changer for their quality of life.
So that brings us to the final thought I want to leave you with. The NCLEX is going to test you on the procedures, the numbers, the protocols, but being a truly great nurse means you take that knowledge and you use it to advocate for the whole person. Their safety, yes, but also their quality of life, their ability to communicate. You're not just caring for a trach, you're caring for a person. Remember that, and you're going to do great. Good luck.